We're now going to dive a little deeper into some of the issues Dr. Heinrich presented with a panel discussion of how academia, government, and the healthcare industry can work together to improve public health. I'd like to invite the moderator for this conversation, Dr. Sylvia Trent-Adams, to the stage, along with your fellow panelists. Dr. Trent-Adams is Executive Vice President and Chief Strategy Officer at the University of North Texas Health Science Center at Fort Worth, and one of the new National Academy of Medicine members that we welcomed last night. Welcome, Dr. Trent-Adams. We have full bios, I'll remind you, at TAMEST.org, and encourage you to look at them. Please welcome Dr. Trent-Adams, who's going to introduce the session and the panelists. Dr. Trent-Adams.
Well, good morning, everyone. It's a pleasure to be here in San Antonio. It's a balmy time to be in Texas, and definitely the humidity of San Antonio has welcomed us in grand style. So I want to say thank you for being here. This topic on how academia, industry, and government can improve community health is one of great interest to me. My background being in public health, being someone who has crossed in all these sectors now and living in the academic world, I think there's a lot to learn from how each and every one of us can play a role in improving community health. I'm honored to serve as moderator for this panel, and today, as we will discuss these topics, we want to specifically focus on how these sectors can work together to improve health in the communities. Dr. Heinrich's presentation this morning is a good segue into this topic, and I'm truly honored to be joined on the dais by Cheryl McClure from Blue Cross Blue Shield and Dr. Robert Phillips in his role at the American Academy of Family Medicine, correct? American Board of Family Medicine. So, there are key ways for government, industry, and academia to work together. And I think the partnership is exactly what it should be, a partnership. There's nothing that we do in any of these sectors that are separate and distinct from each other. Science, innovation, and training is critical for all of us to be well prepared for what we do in our everyday lives, especially in the world of science, medicine, and engineering. But I think that we have seen more and more of the intersection of science, industry, and community coming together as a result of COVID. If never before have we been able to look at how all these components of society come together. We've seen it during COVID. Now, I want to open this panel by saying that there are several things that we can do. What is it that's most important? Well, the one thing that I think we need to focus on most importantly is communication. Communicating and understanding how science is intersecting with business and how business is helping communities is not always well understood. Speaking truth, speaking science, and using data to tell our message is critical and is more important than ever before. There's a need for us to look at the academic setting, and I'll speak from my limited experience in Texas, but I'll tell you what I've learned from working with universities across the country and abroad, is that our models of education need to be updated, innovated, and done in a way that is user-friendly. Students of today are not like the students, I can say from my generation, because everyone learns differently. Now we have students in science and technology who are phenomenal at innovation, but often their ideas are not supported, they're not given the type of leeway that they need to be exploratory. What I would suggest is that as we start to look at new paradigms and new opportunities and new innovation, that we create these new models, such as we did with during COVID. Many institutions I've learned didn't even have an online capability. Many of them didn't understand how to use telemedicine, telementoring to support their clinical programs. These are tools that we can use to better address the gaps, or the lack of knowledge and lack of information in some rural communities, but also in underserved communities. Many students, as I'm learning now, have different and unique ways of accessing information. We have a number of ways in which we can use our academic portals, our academic resources, to better inform communities of what's happening on our university campuses. I never understood the true value of having an ivory tower, whatever that meant and whatever it means today. But those ivory towers have become obsolete. I would venture to say that most of the learning that happens can be improved upon by having a perspective on what's happening not only on the campus, but down the street and around the corner. More importantly, in Texas, what's happening in our broad corners of our rural communities. Agriculture is as important to what we do downtown as it has to do in the hill country and the prairies. And the reason is because agriculture is one of the most important assets to health and medicine. If we do not have children who are showing up in school with food to eat, we're not able to address the needs of nutritional sustenance for our elderly and our communities, then we're not being able to provide the kinds of nutrition that's needed for people to be able to be sustained. But those are the basics. The social determinants of health is where I want to go. We've not been, and I think most of the challenges that we see right now are not necessarily as how people show up in the emergency room. I had this talk that I did several years ago, and I said that the first time we see individuals in our communities when they show up in the emergency room, we failed. As a healthcare provider, I know that most of the care, 80% of care, is provided outside of an institution. The 20% is what we focus on, and 80% of life is not where we spend our dollars. We spend our 80% of our dollars in the last 20% of life. So let's flip that narrative and corner the market on the 80%. Look at the ways in which academics, researchers, and business can partner. Look at employers. What are the needs for employers to be able to make a healthier workforce so that there are opportunities for people to live their best life, live their healthiest life. But partnering with academic institutions and government has been somewhat challenging. And as the previous talk indicated, government, which I have a history of spending most of my life in the government space, government does not always listen to reason. They don't always listen to innovation. It is almost impossible to change policies if there's not an external force. So what I would say is that academic science and medicine have a responsibility to be able to inform the political agenda, inform the policy narrative, to be able to create things and solutions and tools that make sense in the real world, as in that 80%, as it relates to spending the dollars on the 20%, so that we can maximize the benefit of every taxpayer dollar, but every innovative solution that is developed on a campus within our institutions. Now, science and medicine has great value, but if people who need it can't access it, what's the real value? So I'll stop there as we move on to talk about some of those other intersecting components of industry. So I want to think about how we access those opportunities. How do we build partnerships with industry? How do we build the business case for the science, the medicine, and the innovation that we're seeing within the academic or in the healthcare arena? Shara, would you like to share your perspective?
Yes, I'd be happy to share my perspective, and thank you for including me today. I am an executive with Blue Cross and Blue Shield of Texas. I've been working in this, what I would call healthcare finance area since the early 90s, and there have been a lot of changes, a lot of different policy opportunities, but you know, I've lived in this world for a long time now. The rest of my family, they're very into technology. They're engineers. I married a chemical engineer. I have a daughter who's a chemical engineer, a Ph.D. candidate, a son mechanical engineer. He's pursuing a master's, and then you know I have a son-in-law who's an aerospace engineer. And I was spending a little time with them over the weekend, and explaining to them I would be traveling to San Antonio and you know speaking at TAMEST, and they said, "Well, Mom, how did you get invited to that?" And the answer to that is, I know Dancy Dickey, and I have an opportunity to work with her on a collaborative partnership using our data at Blue Cross and Blue Shield of Texas, working with the Texas A&M Rural and Community Health Institute to see what we could do to reimagine delivery of rural healthcare. So that's been a very exciting opportunity for us. Now, Blue Cross Blue Shield of Texas, we are the largest health insurer in the state. We cover about 7 million Texans. Many of you carry our cards in your wallet, and thank you for your business, and I hope we treat you well and cover all of your needs. But the basic unit of data that we collect is claim data. So when the providers in our network when our members access services with providers, those providers file a claim. A typical professional claim includes about 150 data elements. And we gather this information, and it includes demographic information, it includes cost information, diagnoses, treatments, what drugs were administered, what services were provided, and we can marry a lot of that information together. Now, I only represent Blue Cross and Blue Shield of Texas. We're part of Healthcare Service Corporation, which is 5 states, Blue Cross Blue Shield of Texas, Illinois, Oklahoma, Montana, and New Mexico, but we're also part of a larger national organization, the Blue Cross Blue Shield Association. Now, I'm sharing some statistics here because I just want to, this is vast data that we include. It's healthcare data. You know, when we combine all of our claims data with all of these other Blues plans, there is a vast database. Blue Health Intelligence, 25.6 billion total claims are in this database. It represents 6.2 billion pharmacy claims and 239 million unique members that we know something about their health. Now, we can't always tell everything we need to know. We can't always have everything we need to know on a claim, so much of that information is supplemented. Just us at Healthcare Service Corporation, our 5 states, we have 35 million electronic medical records that we collect, again, to supplement that claim data. We have access to electronic lab results, and we're building integration with electronic medical record companies like Epic. So if you can imagine just how powerful all that information is, it can inform academia. We can do terrific research, and we can draw all kinds of conclusions. Now, as we work on using this data in our business, you know, we're always trying to work on how do we compete? How do we try to deliver care more affordably? How can we streamline our processes? How can we reward and influence value within our provider network and with the providers who serve our members? But this data can also provide insights into things like health equity, COVID-19 patterns, cost and quality benchmarking, and risk stratification. We've been sharing our data with academic institutions for years. I mentioned the work that we're doing to help reimagine rural health with Texas A&M. We have 4 different projects with different interventions and observations, and we've turned over that data. We also do a lot of work with Dr. Vivian Ho at Rice. She has studied things like what are the differences in practice patterns among different individual practitioners, whether they're independent, whether they're part of a group, whether they're employed by a hospital. She's also looked at, we recently had something published in the Journal of American, in JAMA, where it was around all the trauma centers. So more and more hospitals are establishing trauma care. What does that mean for your traditional trauma centers? Is it improving the care of the population? Is it increasing costs unnecessarily? And she's also looked at new types of providers, like freestanding emergency rooms that we have here in Texas, and what's the impact on cost and quality. So let me just give you an example, if we can go to the next slide, on one way we've used our data to help influence community health. So through all of our claims data, we looked at, this is pre-pandemic, but we recognized that there were disparities in common diseases, diabetes and COPD in certain communities. So through this branded initiative called Healthy Kids, Healthy Families, we decided to really focus on these 2 diseases in communities that had high prevalence. And so we worked with organizations like the American Lung Association, like the National Kidney Foundation, and others who could design education interventions within these communities, public health interventions to help, again, remove barriers to care, smoking cessation programs, smoking prevention programs, and we were able to retrospectively look at these communities, compare those who had interventions with those who didn't, and we did see a difference in cost. We saw lower cost, lower prevalence in those communities with interventions. Now, these interventions didn't only affect those of our members who carried our cards, it also affected others in the communities who might have been uninsured. So this is just a small example of what we can do. Had we worked with academia, maybe we could have had a better study design, maybe we could have scaled this, done something that's more sustainable, but there are still plenty of opportunities for us to work together to use this vast data to influence public health in our communities. A couple of problems that I think we can work on together, and you know, we're always focused on cost, quality, and access, but I would argue that the cost of healthcare, the rising cost of healthcare, is one of our nation's largest economic problems. In 2020, spending on healthcare in this country went to $4 trillion. This is 20% of our GDP. That means one in every $5 spent in this country is on healthcare, and it's growing every year. And so I think we need to find more cost-effective ways to deliver care, more efficiencies, and I think that there are a lot of opportunities to use that data. Dr. Heinrich mentioned Texas has the highest uninsured rate. Well, he mentioned Medicaid expansion, but Texas has the highest uninsured rate in the state. We're approaching 20%, US average is 10%. That's a lot of uninsured Texans who do not have access to care. And some of those issues that we can work together on to influence policy, I think can serve for the financial and physical health of our communities.
Sure.
Thank you. Bob, would you like to share your perspectives on how can government, academia, and industry work together to improve the health of the communities?
Absolutely. Thank you so much. I hope the conversation moves to community health. I'm going to start with kind of Maslow's lowest rung of need here, and that is just workforce, just access to health care in the state. Texas has the poorest insurance coverage of any state in the country. It is 51st, last in the nation for access and affordability. It is 47th in the nation for primary care to population ratio. And the state has dealt with that largely. I'll say most of my research and my efforts to translate research for policy are at the national level. I have lived in Texas 3 times in my life, but I won't claim to be an expert. So many of you in the audience have helped me with this. But the state has responded largely over the last decade by pouring a lot of money into building out infrastructure, building out medical schools, building out graduate medical education training programs, and about 30% increase in both of those. It's impressive. 6 new medical schools built, another one on the way. It's impressive. It's a really important response. I'll say it's not sufficient. It is a government-type response to a problem, and we need industry, and we need the rest of you to help us in academia to do better. So my talk is really focused on how specific are we willing to get around the metrics of success. How far are we willing to change our training models? As to Sylvia's point, how far are we willing to change our training models? Because a lot of our academic health centers are very wedded to the models they've had for decades. And how willing are we to change the business model for generalists in healthcare? Primary care, general surgery, general psychiatry, because it's untenable as it currently stands. So if you could go to the next slide, please. So the Texas Medical Association report this year trumpets very appropriately the reduction in whole county health professional shortage areas by 30% in Texas. But it still means 1/3 of your counties have less than 1 primary care clinician per 3,500 people. And the map on the left, the cross-hatchings are in multiple different directions because these are health profession shortage areas, medically underserved areas, and medically underserved populations, and it basically captures the entire state. People in HIPSAs, whole county HIPSAs, live on average 1 full year less of life than people who don't. And that's the average. In some of these places, it's 10 years or more. So 1 to 3,500 loses your HIPSA status, but it's not till you get down to 1 primary care clinician per 2,000 or 1,500 people that you start to see the life expectancy rise and you start to see costs and utilization go in the right direction. So congratulations. You know, reducing the number of HIPSAs by 50 is impressive, but we have a long way to climb. The map on the right are all the federal safety net assets in the state. Rural health clinics, federally qualified health centers, National Health Service Corps sites. These are federal investments in shoring up that access and affordability, without which Texas would be in even more dire straits. And the purple haze across the state is the measure of people eligible for services in those safety net settings who are not getting them. hundreds of thousands of people who need those kinds of sites to access care because they don't have insurance or they don't have proximity to care, but aren't getting it yet. So more federal assets would help this, but I think there are things the state could do too. So these are data in a geographic representation so you can actually visualize what's happening. On the left, we spent the last 5 years convincing U.S. News and World Report to move to a data-driven set of metrics for medical schools. In JAMA last year, we called this moving from a beauty contest to a talent show. So the typical rankings are a beauty contest, but the talent show is using the raw outputs of medical schools, looking 5 to 7 years downstream, where did their graduates wind up in specialties and in geography? And so when you look at University of North Texas Health Science Center, 40% of their students 5 to 7 years later are in primary care roles across the state. That's pretty impressive. You need to stay above 30% in order to maintain the primary care workforce that you have. University of Texas Health Science Center, Houston, 21%. Only 3 schools are above that 30% line in the state. And I put a little asterisk next to this because we're not able to account for generalists who are going into hospitalist roles. And this is important because if you look back last month in JAMA, the American Board of Internal Medicine showed that more than half of their internal medicine trainees will go into subspecialties. And most of our metrics around primary care are just looking at people who leave medical school and go into primary care potentially through training. Half of them in internal medicine will not go into primary care. 80% of those who do go into just generalist training tracks will become hospitalists. So you're down to 10% of all general internists now going into primary care. The number of family physicians becoming hospitalists or ED docs has gone up 100% in the last 10 years. So it's gone from 7.5% to 15%. So we are losing our primary care workforce. So it's like trying to fill a bathtub, but the hole in the bottom keeps getting bigger. So the state is pouring resources into filling that tub, but the hole just keeps draining. So we need to work on how do we make primary care viable for those people to go work in primary care. The second set of measures there, I have Texas Tech University. About 8% of their students are going into rural areas. I know 15% of the population is rural nationally. In Texas, it may be higher. But we're only putting 8% of our workforce into rural areas. And Baylor College of Medicine is under it's about 1%. Only 3 schools are higher than 5%. So if we're going to get specific in our metrics, we really need to look at what are our training programs producing, where are they going, and who is actually supplying the workforce we need where we need it most, so that we can direct our resources more effectively. Next slide, please. You all did a very interesting experiment when you implemented your 1115 Medicaid waiver 8 years ago, 10? There was a requirement embedded in that all 61 nonprofit hospitals and all 20 regional health partnerships had to do a needs assessment in their accountable geographies. What does the primary care need? What does the mental health workforce need in our area? And what they wound up showing is that 26 of 38 of the community health needs assessments by the nonprofit hospitals showed a need for primary care. 34 of 38 showed a need for mental health. In the regional health partnerships, 18 of 20 showed primary care need and 20 of 20 showed mental health need. The direct goal of that was to implement training models that would start to address that need, yet only 3 of 36 of the nonprofit hospitals developed a plan for addressing primary care, and only 1 of 36 to address mental health. 5 of the regional health partnerships developed one for primary care and 3 for mental health. So the need was very obvious, but the response to it not quite as aggressive. And so that brings me my first question: how specific are you willing to get about the metrics you're using for success in meeting need in Texas? Because, to our first speaker's note, it forces us to look at a reality that we have to address. The second is that our training models just aren't producing that workforce. So we need to move them out into community. We need to move them out into partnership with community. We need to move them to rural areas, quite frankly, and I'm so glad that Blue Cross Blue Shield is making that investment, because we're not going to get them to go there or stay there if we don't train them there. And then lastly, of the $1 out of every 4 that goes into healthcare, 1 nickel goes into primary care. And yet that's where most people go for their healthcare needs. That's where most vaccinations are given. It is the platform that provides most care in this country. But we underfund it, and so when that general internist or that family physician is trying to make a decision, do I stay in primary care or not, when they're looking at a 50 to 75% increase in income by going to emergency room or a hospitalist role, or they're looking at 2 to 4-fold increase in salary by going into a subspecialty role, and we've shown that you cannot afford your mortgage and put your kids through college given the debt level that most people leave medical school with by taking a primary care track. It is really hard for them to make that decision, and very easy to understand why they make the different choices. So we need to change the business model. We need to change the business model where we train people, and then we need to reach, like University of Houston is, into those underserved populations to bring that pipeline into that production model so that they are going into the communities where we need them most. So thank you. I'll stop there.
I think you've hit on a lot of high points, and I think for me, there's a sentinel message around supply and demand. We know that we have an aging population, we have an increased obesity and mental health challenges here in the United States, and especially in Texas. We have an uninsured rate that we talked about earlier. There are not enough resources to meet all the needs of the population here in the state, but the state is growing by leaps and bounds every single month. One of the things that we do have the value of is great technology and engineering and health and medicine resources here, But scaling those resources to meet the needs of the population will indeed require re-engineering the model. And what I would pose is that we have to think about where do people access care and what kind of care are they accessing versus what they need. If we focus on prevention, we start to look at health education, we start to look at prevention as a part of the fabric of the community, that it is not taken for granted that someone who is born into an underserved community needs access to transportation, food, nutrition, as well as education on how to maintain a healthy body weight, I know I'm preaching to the choir, but there are some things that we need to do in academia, in government, and in business to make sure that those resources and those tools and that mindset is not only there, but can be replicated across many communities within the state. So I would ask of you, both of you, can you think of some of the agile, more robust models that could be leveraged to be able to create those opportunities for partnership?
So I can take on a couple of those, and so you talk about models, and I heard you talk about, how do we change the equation, how do we make it more attractive for people to go into, physicians to go into primary care. And so there are a couple of models. First, let me just touch on the easy one, and one is telehealth. I mean, we've seen so many access points for telehealth since the pandemic. So prior to March of 2020, we saw in our claims data and what we saw coming through from healthcare providers was very small. I mean, less than 5% of care was delivered through telehealth. And of course, when we saw the pandemic in March, everything shut down. People were afraid to access care. Elective services were shut down. And of course, we saw a spike in telehealth, which kind of, it expanded capacity to a certain extent, but it was also a need. We had to evolve the way we delivered care at the time. Now, I guess we're still in a pandemic, but we're still seeing a lot more care delivered in offices. It's not as restricted as it was in the past. Well, what we've seen is for medical care, it might have doubled. The telehealth might have doubled, but it's still under 10% delivered in a telehealth setting. But for behavioral health, it's sustained around 50% delivered in a telehealth setting. And so I think that is a way that we've potentially increased capacity. We've seen it a little more sustained in the behavioral health side. So another observation is, okay, well, who's delivering the telehealth? Because you see all these, what I'll call vendors, your MD Lives, your teledocs. You have a problem, you call, you might have a face-to-face encounter with a physician that you don't really have a relationship with. They're not your normal primary care physician. And although we've seen increases in utilization from those vendors, the overwhelming majority of telehealth is being delivered by your traditional practitioners, those who actually have relationships with the patient. So I'll use that as an example. I think we might get into different business models on how to incentivize primary care, and I'm happy to talk about that, but I also wanted to give you an opportunity to weigh in.
Shara, that's actually really good news, because one of the concerns about telehealth is that it violates relationship. But you're right. I think a lot of primary care physicians and mental health providers are using telehealth to leverage relationship and make it easier for people to get care. I think there are technological solutions that make sense, but I think most of the solutions we need are adaptive. And where I think Agile can really help us is figuring out what does a rural health clinic need to look like in order to actually address patient and population need. How do we design it? What is the funding that it takes to sustain it? What's the workforce look like to make that work? And then how do we back up in the business model and figure out how payers can support that? The National Academies a year ago, released a report on implementing high-quality primary care that talks a lot about this, but we need business to help us figure out what does that model look like and how do we make it work so that we can bring the right team to the right needs of the population.
Yeah, Bob, I would agree with you. I think it is a team-based approach that's going to be sustainable over time. And one of the reasons is because of current supply and demand imbalances and the burnout rate in physicians and primary care providers. And we're seeing more physicians at that point where they would typically be at the peak of their career leaving medicine. You're seeing nurses and pharmacists doing the same thing. We have to figure out how do we deliver the right team to deliver the right kind of care, and especially in rural and underserved communities. And in rural communities, some of those models that have worked that are low cost are using community health workers, using promotores, using other solutions to be that front line, forward-facing entry point into care. They're trusted, they know the language, they know the culture, and they're more than likely to be able to be the gateway to a provider, taking that burden off of the health system, so to speak. But creating them as a part of the team, I think, would be essential, especially in some of these more underserved communities. The other thing is using some of the tools that you talked about, but taking the walls down around what we think about healthcare being. And I would say, let's blow up the model and start all over. And that sounds kind of revolutionary, but it's what we need at this point because the model is not sustainable. We can't afford it. And we're generating technology that will only be available to a very small population. And if the great science that we're developing in our labs and in our institutions cannot be utilized, then how do we sustain the growth and development and embodying that part of that technology as a part of what we see as being growth and development in science and being able to change health outcomes?
No, I completely agree. So I run a national primary care registry, a clinical registry. We had about 800 practices before the pandemic in 47 states. An incredible radar of understanding what's happening across the health system. We lost 140 practices during COVID because the resilience, the margins are so thin. They lost 27% of their business in the first 3 months of COVID and never came above water even through December of 21. So practices closed, practices sold themselves to health systems, but they were saving throws to try and salvage these small practices across the landscape. And so there's a fundamental need to just make them more resilient. And then there's the need to how do you bring in community health workers, how do you bring in nurses, how do you bring in pharmacists, mental health providers so that they can actually meet the broader needs of the community.
Great. Well, thank you. I want to give everyone an opportunity to have a chance to ask questions if they like. And I want to close with this. There are opportunities for academia, government, and business to work together. The key is going to be finding those solutions that are going to be amenable to all of us finding our space in that place and be open and willing to make the changes that are necessary, that are critical for improving the supply and demand of primary care providers and sustainable models that will be available to all of those who need to access the healthcare delivery system. So at this time, we'll open to questions. There are mics that are set up in the room. If there are any questions, we'd be happy to take those at this time.
Hi, Paula Shireman, Texas A&M. Thank you for an excellent session and highlighting the needs of rural Texas, which is actually one of the foundations of our medical school. So one of the critical is that most people live in cities and they have had no access to rural communities. So they train and they have no idea that being a physician in a rural community, you are a pillar of the community and you are a leader. So how can we help? And we are developing pathways to put medical students and residents into rural communities as part of their training, so they now see this as a viable option rather than something they would never ever do. How do we, expand and do that? Because we can train all the physicians you want, but if we don't expose them to rural medicine and the advantages and disadvantages, because they're both, how do we expand these programs? And then, of course, as a secondary thing, how do we pay for the promotores? I mean, we get a grant, we have them, they go and do wonderful things, the grant expires, and there's no funding mechanism. So how do we work with Blue Cross Blue Shield to be able to afford clinicians and people who can go to the community who are much lower costs than me, a vascular surgeon, to deliver this care and make it sustainable from a financial business model?
I think that that's a very challenging question, because we do have a lot of data, and we're in a competitive business, right? So if we invest in one area but we outprice the market, and employers choose other health plans that can deliver, that can cover their employees less expensive, then we've got to compete in that marketplace. One observation that we had in our data in many of these rural communities, I think there have been like 26 hospitals in Texas that have closed down since 2010, kind of leaving those communities without an emergency room, without, they have a helicopter that might be able to take them to a metro area, but that's not exactly a cost-effective way to deliver care as well. But as we were looking at these communities that were losing their hospitals before and after the hospital closed down, we were finding that the individuals for insurance that had insurance, that were covered, that had the means and had access to the metro areas, they were accessing their care in the metro areas that had higher volumes, that had potentially higher, more experienced faculty, and they weren't choosing to get their knee replacements, or even sometimes delivering babies. If it was a elective, they were going to those metro areas. So I don't know the answer, but perhaps there's a responsibility of those metro areas to kind of help with those rural communities and extend their reach into rural communities where the payer mix might not be as attractive as it is in metro areas. Again, that's just a potential idea.
So there's two ready opportunities. I'm not going to say either one of them are easy. One is the state puts about $150 million into graduate medical education through Medicaid. There are no strings tied to that money. They don't have to follow the Medicare graduate medical education payment model, but they do. You could spend those dollars quite differently to build out a rural training capacity. But it would mean that academic health centers would have to be willing to give up that money to do it, or become partners in that effort. The second is that critical access hospitals are funded differently than other hospitals, and they can actually build training costs into their cost basis. And you're starting to see this around the country, where critical access hospitals come together with academia to build rural training sites, and they use the funding from the critical access cost-based reimbursement to do it. It's really starting to take off, and that could be a model that Texas could use as well.
I would encourage you to also consider the need to speak up about where clinical rotations are happening. Because I will tell you, if you don't create opportunities for clinicians to rotate through, and that's all of the clinicians, whether it be physicians, nurses, pharmacists, to rotate through those rural areas, they're more than likely not to practice in those areas. So increasing the rotations in rural areas. The other one is around partnerships with employers in these rural communities. In Texas, you've got a lot of oil industry that need providers when there's high demand for employees. If your employees are not well, they can't work, and it attaches itself to the bottom line just inherently. But creating those partnerships with businesses to partner with then community colleges, high schools to create pipelines to medical schools and colleges is one other solution that some communities are doing. We have at the Health Science Center in UNT, we have an agreement with Midland, and we're doing pipeline programs from Midland, and those providers go back, those physicians go back there. But there are other areas of the country that are doing similar types of programs. And the other one I want to say is the private market is looking at models for value-based care. And there will be some for-profit arenas popping up to show that if we can create this model and they'll sell this service too, then they will go in and provide that service for a cost. I'm looking at these mobile clinics that are now in other parts of the country. I know you're familiar with this because Blue Cross and United Healthcare is doing a lot of research on this. If you have mobile clinics that can go in and do vaccines for a cost to a municipality, it decreases their lifelong cost of absenteeism in schools, absenteeism at work, and what is the community value. So communities are investing in these mobile options, and they're doing this on a rotating basis. So there are other solutions to figuring out how to get care to communities, and there are providers who want to do that kind of work as well. Yes.
Thank you. Richard Gibbs, Baylor College of Medicine. My question is a little like the previous one, but it's not about the broad face of care. It's more about specific innovative technologies, since we have many examples where we have a great new test that has some value in the clinic. We'll know it'll be enhanced if it gets traction, but the payers will not let it get there from the beginning. So is there any reason to be optimistic that anything will come from the payers to change that paradigm?
So I think you're talking about medical policy, so what's covered, what's not covered, and we have teams of clinicians who, they look to the FDA and the other organizations on what we will cover. And so we do not typically cover experimental investigational services. But I think that perhaps if the clinical trial model changes, if we see accelerated evidence on different new technologies, we might see that accelerate, but I think that will probably go at the same pace as government.
I will add this. If CMS understands a business line for a new technology, CMMI will pick it up, and then it can get on the formularies, but only with a business case for it.
Yeah, I'm taking this as a maybe.
Over here.
Hello, I'm Nicholas Pepos, and I am an engineer, and at the same time professor in the medical school at the University of Texas at Austin. A wonderful panel, so many questions to be answered. I happen to be somebody who believes we have to act now. We don't have to wait for the new models and practice them and so on. But this is for another time, not for right now. But right now, I want to answer two questions. One about the previous talk, which was an absolutely glorious talk. The Moderna product did not come 2 days after it was needed. Bob Langer has started working on the Moderna product 10 years earlier. So it will be nice to read it because especially he got the BBVA award late last week in Bilbao, and he and Dr. Carrico really talked a lot about how the Moderna and the Pfizer started. But I want to answer to you, Dr. Phillips. The rural problem is a serious problem, but here in this state, we have a university that is dedicated to that. And I think the president of that university, Dr. Laurie Sperman, is here, Texas Tech Health, and they have units in Abilene, in Amarillo, in Midland, in Odessa, and they send their people on the field. And I want to congratulate her and the university. And I know you, like me, you're a member of NAM, and you're quite familiar with really what we try to do in NAM. So no questions, just a few comments, and really an excitement. We need to work now.
Yes.
People need us right now. Let the models progress, but in the meantime, let's work. Dr. You're here. She's here. She's the president.
So Sylvia, thank you so much. I will tell you, I was sitting in the back of the room listening, and as someone who grew up in a small West Texas town with very limited access to health care, I'm encouraged that we are gaining the attention of the need for rural health care in Texas. Our university serves 108 counties along with our sister university, which is larger than 46 of the 50 states in the United States. 52 counties that we serve are considered frontier, which means they have no access to primary care whatsoever. Right now in Fort Davis, Texas, there is no access to primary care. Alpine, Texas, which has a regional university, has very limited care for women's health. And if you're pregnant in Alpine, Texas, you have to travel over an hour to deliver that baby or to get specialty care. We have a crisis in rural West Texas. That is the home of the food, the fiber, and the fuel of Texas, and in some cases, the nation. We are working as hard as we can. We have some innovative programming in rural Texas where we're working on the largest family medicine rural program, which covers cities like Monahans and Pecos and those small areas out there, trying to get residents into these areas. But let me tell you what these residents are facing when they graduate with an OB or a family care or that type of specialty. They can't sustain practices in these communities. And so we're training them in the communities. They can't afford to live there, and the school systems are below what they should be. So they don't want to raise their families in those communities with those disadvantages. So this isn't just a healthcare issue. This is an education issue. Because there's one thing that we know for sure. West Texans are dying at a higher rate of diabetes and heart disease than in our cohorts on the east side of the state. So I'm actually sitting in the room feeling encouraged that this is gaining the light. People are starting to see the value of what's happening in West Texas and how we have to take care of rural West Texans. So thank you, and I'm here today and tomorrow, and I'm happy to answer any questions.
Great. And I just received, this is our last question.
Oh, okay. So, hi, I'm Pia Ghosh. I'm one of the proteges from UT Arlington. And I think it's very cool that we have a very professionally diverse panel. And I guess I think about education a lot. And I think health education is beyond the clinician. And so I guess what I know of many students who I feel would be very interested in these issues, but don't know to be interested in these issues. So I was wondering if there are any comments you had or any ideas you have of how we can implement education at the high school or college level for career tracks that address these issues apart from being a physician. I think it would be very, very valuable.
Well, you know, I don't know how many little boys and girls sit in bed at night and dream about being in health insurance, but I do try to take the opportunity to talk to students, primarily college students, sometimes interns at our company. And you know, they think that the money's in investment banking or oil and gas or, you know, real estate. Healthcare is bigger than all of those combined. And I don't know that they realize the economic crisis that healthcare creates and what they're inheriting. And so I try to talk to them and encourage them and not scare them. But we need some great minds to focus on affordability in this country.
And I'd say that we need to start earlier. We need to start in the elementary schools. We need to show up and be there in those schools, and if it's mentoring partnerships that the universities, that businesses, and also community leaders create those opportunities in the elementary, middle, and high schools, because if we start to get pipeline programs into high schools, it's too late, because they have not been exposed to the rigor of math and science and technology along the way to get them into places and spaces where they can be successful. Because what happens to a lot of our students from rural communities and from underrepresented populations and communities is that they don't have the rigor and they can't see themselves being successful in the academic arena. So set them up for success from day one, elementary all the way through, and be present and help them to understand that they can be in the places and spaces where they see others to be successful.
Thank you very much.
Thank you. Well, I think that concludes our panel. Thank you for your attention, and we'll be ready to move on.